everyone. Welcome back to another episode of Lessons from the Lab. My name is Devin Rubin from Mayo Clinic in Jacksonville, Florida, and it's fantastic to be back with you again for another episode. I am certainly thankful to be able to host this Lessons from the Lab and have a wonderful guest that I think we all are going to learn from. Sit back and enjoy this episode. Well, it's wonderful to be here recording another episode of Lessons from the Lab. I have an outstanding guest with me today, Dr. David Del Toro. Dr. Del Toro is a professor of physical medicine and rehabilitation at the Medical College of Wisconsin, someone I've known for a long, long time as we started in AANEM together, and it's wonderful to have you here, David.
Hi, Devin. Good to be here. Thanks for asking me to do this. I'm looking forward to it. I'm very excited about this opportunity.
Yeah, we were just talking before we recorded that I wish you were down here. I know it's nice in Wisconsin for another day or two, but winter's coming and it's Thanksgiving week and summer's coming in Florida during Thanksgiving. It's always nice here. So sorry you're not here with me.
Yes, the weather will be changing. Fortunately, we had nice weather over the weekend. It was in the low 50s, but I looked at the weather report and it will be down to the 30s by the end of the week, possibly.
Yeah, I love those old days when I was up there, but you'll survive.
Yes, thanks.
So we go a long ways back. I was thinking about this morning as I was preparing. I think we were on. I think the first committee I was on at AANEM. I think we were on the same committee together, if I remember, years ago. But I can't remember what that committee was. That's how old I'm getting.
Yes,
Do you
I know
remember?
I've been on a number. It might have been the practice parameter. Um,
Yeah.
because
Yeah.
I've been on so many committees that, yeah, I've lost count on how many. If not the practice parameter, it could have been the workshop one. We were on that. There's also the educational committee. It could have been that one as well.
Yeah, that's right. I think I actually went back. One of my early committees was the Digital Education Media Committee. And I think I was on that before we even had cell phones. So it was an interesting committee trying to develop digital educational products. But I went back and I looked back at an old email from maybe 2009. And I had an email from you, and it was when you were developing your DVD on the foot, assessment of the foot. And I think I
Okay.
was on the committee that was reviewing that. So I asked you a few questions about some of the content, and you responded. And I remember I was reading that this morning and thinking, wow, I've learned a lot just from the questions that I asked about that DVD. So you
Yes.
remember putting
Yeah.
that together?
Yeah. I do remember putting that DVD together with Sanjeev Nandekar, and I went to New York at his home with him and his wife Anjali. That was a wonderful experience putting that DVD together, and I'm so glad that the ANEM still uses those. And I mean, we put a lot of work into that. And a lot of the education that comes out of those DVDs I think, is priceless. It's not something that is necessarily done on at least on a regular basis. So to preserve that and have the ANEM promote those, I think that's a joy to see. And I think I'm sure that a lot of members that utilize that still get a lot of information from that.
Yeah, yeah, it was terrific, and all of those, I think thinking back, and it's good for people listening to know how much educational material there is through AANEM. We don't use DVDs anymore, but I think a lot of that, and I'm sure Sanjeev has converted a lot of those to digital media that we can utilize. But yeah, there was a lot of effort that went into that, and those type of products, and they're terrific. And for younger physicians and even physicians who have been doing this for a long time, those resources are fantastic to kind of improve and elevate the knowledge that we all have. I certainly continue to use those.
Yep. Yeah, I think that there are so many different ideas and so many different topics that Sanjeev and other AENAM members have done with that. So I think they're definitely valuable to, like you mentioned, young up and coming electromographers, but even ones that just want a refresher. There's so much information in there. And it's nice that he has, you're right, he has converted them to online modules.
Yeah. Yeah. So anyway, we should have we should cut to an ANEM advertisement on this because it sounds like,
Yeah,
but I mean, we're part of the ANEM. This is the educational product too. And so it's good for people to be aware of what's out there. So,
absolutely.
so I mentioned it's almost Thanksgiving, and I'm going to ask you before we get into the case, do you have anything that you're thankful for this year from a professional standpoint? I'm not, I know we have so many personal things we're thankful for, but anything from a professional standpoint?
I think, just still being in academics, I would not have foreseen that I would have stayed in academics this long. I've been at the Medical College of Wisconsin for over 30 years. I love still teaching residents, students, young faculty members. I was asked to be on our professional development committee as we're trying to get some of our young faculty promoted. And I'm just thankful that I'm have the opportunity to be in academics, and I feel like we're always learning something.
I agree. I would say almost the exact same thing. I was thinking about how I would answer this, and I agree. I think I'm certainly thankful for being in that situation. I'm thankful to be able to help educate and be able to continue to learn, and that I have the capability, although some would say I don't, I'm a lost cause, I can't learn anymore. But it's nice to be able to continue to learn and to help our patients and to improve what we do. And I'm very thankful that we have the opportunity to do that. And I'm thankful to be able to learn from you during this lessons.
And
So
I'm sure I will learn from you as well. Looking forward to it.
yeah. So anyway, let's I know you're familiar with these, and so basically the goal of this is to present a case. I know you don't know this case, and to just kind of talk about whether you've seen something like this and how you would approach this patient in your EMG lab or in your clinic, and see if we are similar or different, and kind of what you would think about this case. So so you ready?
Yes, I am ready.
Okay, I'm going to share my screen here. And like, can you see the blank slide?
Yes.
Okay. So I'm gonna and I'm gonna read this. Some people will be listening to this just on podcast. They won't be seeing looking at this on YouTube. So I'm gonna just read this case for you and for those listening.
Okay.
So basically, this was a patient we saw a few years ago now. He was a 62-year-old man who presented for evaluation of numbness in the bottom of his left foot. And he basically had the symptoms that came on gradually about 2 years prior to us evaluating him, and it had progressed. And he described the numbness as mostly a decrease in sensation, but there was a little bit of tingling and a little bit of pain. And he was vague about the pain. It was kind of an achy pain, maybe occasional shooting pain, and it was just on the bottom of the foot, on one foot. He also
Okay.
noted some difficulty balancing on the left foot. And other than that, he really didn't have any other symptoms. So no back pain, no proximal leg pain, no right foot symptoms. That was it. And on his
Okay.
neurologic exam, the basic exam, he had normal strength, he had normal reflexes, including Achilles, and he had decreased pinprick sensation on the plantar surface of the left foot. And the rest of his exam was
Okay.
okay.
Okay. Can I ask one question?
You can ask as many questions as you want. I may
Any
not have
history
the answer, but
any history of trauma?
he did not have any history of trauma.
Okay. And maybe I'm jumping the gun, but any past medical history of um, systemic disorders like diabetes, history of cancer, chemotherapy?
No, he was a healthy guy, no diabetes. Um, there was nothing significant in his history. No cancer. He might have had high blood pressure, but nothing that I think would be really relevant.
Okay.
So, so you want to ask more questions? They're free.
I think that's good for now.
Okay. So let me start off and ask you, and it's interesting because I had another patient this morning that was a little bit similar to this, and I was working with a PGY2 neurology resident. So I asked her, and I'll ask you, although you're obviously much more experienced, but what do you think, what goes through your mind in terms of potential, I guess, localization, or what do you start thinking about when you hear the story like this?
Well, even though there's no history of back or proximal leg symptoms, I would still have in the differential as some radiculopathy, likely in this case an S1, if the sensation is diminished on the sole of the foot. Um, and I mean, certainly tarsal tunnel would be a consideration. Um, and I still might think of some sort of asymmetric polyneuropathy.
Okay.
And from a neuromuscular standpoint, those would be kind of the yes, the starting with that differential diagnosis. Um, I think without any history of trauma, I wouldn't think there would be anything local, um, and without any history of cancer or chemotherapy, that would be then less likely for and no diabetes, et cetera.
Mhm.
The peripheral polyneuropathy wouldn't be as likely, although, as I said, it could be something asymmetric and not showing up on the right side.
Yeah. And when you ask about trauma, or do you ask, I mean, we obviously want to know trauma anywhere kind of in the region, but are you more concerned about trauma around the foot or just the whole leg
The
or
ankle, yeah, I mean, at
Mhm.
the foot, for obvious reasons, if there's something local that happened on the sole of the foot, but also if something happened at the ankle, even something higher up could cause, if it were primarily a tibial nerve involvement, let's say they had a dislocation of the knee. I've seen people that have a dislocated knee and had a sciatic nerve or a combined tibial and fibular or peroneal nerve injury where one nerve was injured more than the other. In this case, it would be the tibial, of course. But at the knee, you'd expect some proximal leg symptoms.
Mhm.
But depending on fascicular involvement, you could have potentially just the tibial nerve and the portion of the tibial nerve that primarily goes to the sole of the foot.
Yeah. I've seen some patients, I don't know if you have, who have had, they haven't had trauma, but they've had knee surgery or blocks, and they come out
Yes.
with the tibial neuropathy.
Yes, yeah, that's a great point. I have seen definitely in my time probably more than half a dozen or more, probably yeah, a couple dozen of nerve block cases where, especially since it seems as though there are a fair amount of popliteal blocks
Hmm.
that they do, sciatic nerve blocks. They do femoral, of course, but that wouldn't, that wouldn't be relevant in this case. But the popliteal blocks and the sciatic nerve blocks, I definitely have seen um, neuropathies isolated to either the fibular or peroneal nerve or the tibial nerve or both.
Yeah. It always scares me when I see those because I think, gosh, man, if I have to have surgery, I don't know would I rather have a block or would I rather have general anesthesia or I'd rather not have surgery. But it
Yes,
scares you when you see those and you think, gosh, I hope that it never happens to me because they can be
yes,
really
I know.
debilitating. I mean, the patients are a lot of pain and yeah, the
Yes,
patients I've seen, it's really bad.
yeah. I think, and Devin, you and I are probably in the same sort of same boat, so to speak, when we're seeing these patients because we're seeing the worst of the worst. And if
Hmm.
someone is that bad that they need an EMG, in general, they likely, especially post surgery, they likely have some sort of deficit, and that is pretty unfortunate for that patient. What I tell myself if I ever have to have something like this, which, like I said, I hope I don't, is that because we see the worst of the worst, we never see the good ones and the people that have great outcomes and don't have any complications.
Yeah. So you don't have patients that just come to the EMG lab just because they heard it's fun and just want to have it? Yeah.
Not so much.
Not too many.
We have
No.
residents that do that.
Yeah. Yeah. Well, okay. So yeah, I would be thinking the same as you. In fact, it was interesting with the resident this morning. Well, I didn't present this case, but I had these slides up because we were in preparing for this. And, the resident hasn't done much peripheral nerve. So asking what's the localization is always interesting. But I pulled up this, which and you hit the highlights. And interestingly, I would be thinking the same thing. So this is just for those of you who are listening, a picture showing just a general picture of the plantar surface of the foot and some of the branches and possible localization. So as you said, David, thinking of S1 root, tibial nerve, and then like you said, a polyneuropathy. So this was timely that I was given this and I could pull this up for the patient we saw. I
Right,
think these
that's good.
the other things like plexopathy and I think that would be a little unusual and sural nerve wouldn't really cause the symptoms on the bottom of the foot. So, all
Right.
right. So how do you approach this patient? If this, let's say if this is you're working in the EMG lab, what would your approach be and what do you do?
So I think well, part of it would depend on if, and we're a teaching hospital, um, and so I would sometimes if I have a resident or a fellow with me, I might start more generic and then go down to something more specific. In this case, given he's 60 something, is that right?
Yeah, 62.
Um, So more than likely, I generally like to get a normal nerve first, whether it's motor or sensory. In his case, 62 should have good tibial motor CMAPs. So I probably would start with the motor, and part of the reason would be, especially if I have a resident or a fellow, is that if I get a good tibial nerve CMAP, whether it's the medial plantar, lateral plantar, that at least tells me that, okay, it's got pretty good CMAPs. If they're small, or let's say they're like small or puny, or they're kind of temporally dispersed, then that's going to kind of raise my suspicion. And without even going to the sensory, I probably would jump to the other side as a comparison. And just to throw some numbers out, if that's okay, if
Yeah.
the medial plantar CMAP recording over the abductor hallucis, let's say it's 3 millivolts, I would be like, wow, that's pretty small, even for someone in their 60s. Or if it's broad-based, temporally dispersed, then I would be like, yeah, this looks kind of sickly, so to speak. I want to jump to the other side and see what that looks like, to see if there's any asymmetry. And let's say the other side, the medial plantar CMAP was 10 millivolts. Then I'm like, okay, this is definitely something that is unusual, and I'm focusing now more on, is there a tibial nerve problem on that side? And then I would proceed with a few other motors, like the lateral plantar motor, plus minus Baxter's nerve. I probably wouldn't necessarily have to do Baxter's nerve. That's usually if someone has heel pain. So, or someone could have tarsal tunnel, it could be involved, but at this point, it's not completely relevant. So the lateral plantar CMAP would be the next one, and depending on how that looks, probably would most certainly do the deep fibular or deep perineal recording over the EDB just to see if this is something that's affecting multiple nerves in that foot, or is it just primarily the tibial nerve, or it could be like a tibial branch, what I call a tibial branch neuropathy.
Okay. That's great. That is
Sorry,
generated
that
about
was a mouthful.
15 questions in my mind. So, so
Sorry.
no, 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 this is great. This is great. And so first of all, it's interesting. So when you're saying you would do the medial plantar motor and the lateral plantar motor, you're talking about uh, stimulating at the ankle and recording over the abductor hallucis or abductor digiti minimi pedis. Is that what you mean?
The
Rather than
extra,
rather than
it
stimulating
would
at the
be stimulating at the ankle, you're right, and then recording over the abductor hallucis, that's for the medial plantar. For the lateral plantar, you'd be recording over um, basically the midpoint of the fifth metatarsal shaft.
okay.
Um, there's a small muscle that you're recording over the flexor digiti minimi brevis, but obviously since you're stimulating the tibial nerve at the ankle, you're getting a compound muscle action potential, but the recording site should be over the midpoint of the fifth metatarsal shaft.
Okay. So you're not referring to what we often refer to when we say medial plantar, lateral plantar, the stimulation in the plantar surface of the foot and recording orthodromically more sensory fibers up to the ankle.
Right. Yeah. That I consider a mixed nerve action potential, similar,
Okay.
like you said, like a sensory. And so you're expecting that response to be microvolts. No, the one I'm referring to is more of it's a motor
Is the
response,
motor.
so it should be, yeah, millivolts.
Okay. Okay. Gotcha. So let me just show you the first couple conductions we did. So what we did is we did the fibular first. So I agree with you. There's, and this is always interesting when I'm doing these because I always say there's no right or wrong way of doing this. There's different approaches. So I would want what I expect to be a normal nerve and
Right.
expecting that the tibial nerve possibly is affected, get the fibular out of the way and make sure it's normal because if it's abnormal, then we have to start thinking, is there something else going on? So,
Right.
but you said you
Okay.
would do
Yeah.
it too. You might just do it in a different order.
Yes. Yep. Yeah, because I definitely would do the fibular motor. You're right. It's a matter of when I would do it.
Yeah. Yeah. Okay. So would you agree that looks pretty good?
Looks very good.
Looks good.
Yep. I like your colors too.
Yeah. Yeah. For those of you who can't see, we have our normal values, in our machine. So if it's green, green is good. Red is
Yes. Green is
abnormal for our
good.
lab. Yeah. So
Yep. I do like
fibular
that.
looks good. So here's what I guess what we just call our tibial, but this would be the medial plantar motor branch to the abductor hallucis.
Yes. And yeah, that looks pretty sickly, as I
Yeah.
was saying before. Yeah, so if I got that, I would definitely want to compare to the other side to see what that looks like.
Do you think the slowed velocity, so the velocity is 37 in our lab, it should be over 40. So it's just a tiny bit
40.
slowed. Do you does that do you make much of that or because it's so low amplitude that doesn't mean a whole lot?
Exactly. I think the loss of axons from that really small CMAP would potentially account for the conduction velocity being just under the normal limit because we use 40 as well. But I mean, yeah, it wouldn't raise my suspicion too much of something necessarily thinking demyelinating. I'm still thinking, potentially it's an axonal process because of this small CMAP.
Okay.
But again, we need to collect more data.
So you would go over to the other side at this point.
I probably would do the lateral plantar just to see is it affecting more than one branch of the tibial nerve in the foot, especially
Okay.
because since we're stimulating in the same place, from a efficiency standpoint, it's easy to just put my electrodes, put the E1 and E2 over on the lateral side of the foot. I have my stimulation site already. I also have my stimulation parameters with respect to the stimulus. I don't know if you use milliamps or whatever, but since I know what I need to get super max,
Yeah.
it's pretty easy to do the lateral plantar one while I'm here.
And I'm going to show you another slide here in a second, but I'm going to ask you, so if the lateral, so how does it help you to do the lateral plantar too? Is it just because, as you said, it's telling you that two branches are affected, but if you're thinking the tibial nerve at the ankle, you would want to see both branches affected. Is that kind of what you're thinking?
Correct.
Okay.
Yes, yeah, because I've seen a number of, and this is my bias over the years, Devin, is that I would say the majority of people that have tarsal tunnel, it is something that is either a space occupying lesion, like a mass, or trauma, or post surgical. There's very few of the sort of biomechanical problems that I see. Just not, yeah, I just haven't seen that. It doesn't seem to fit with the electrodiagnostic findings. But then I've also seen a number of cases that just a tibial nerve branch that was involved due to trauma or a space occupying lesion, something within what's called the one of the calcaneal chambers. So the medial lateral plantar nerve, they travel in their own chamber that's made up of the adductor hallucis, the deep fascia. And so those, as they separate and they go in their own chamber, there have been reports of a mass or some sort of space occupying lesion that affects one of those nerve branches.
Okay. So if you did the lateral plantar and it was normal, then you would think whatever's going on is affecting that just the branch, maybe in
The
that
medial
chamber.
plantar.
Yeah, the medial. Yeah. Okay.
Yes. Yep.
And I'm going to show this picture. For some reason we didn't do that. We often do what you said, and I don't know if this is the way you kind of set it up. I don't know if you can see this. We didn't do it in this patient, so
Mm-hmm.
this is not from this patient. But I just wanted to show because I had a feeling you were going to bring this up. Is this how you do the lateral plant? You record here when you do
Yes.
the okay. So
Yep.
this is the
Yeah, that
medial
one on the
plantar.
right. That is, yeah.
Yeah.
And although I will say the ADMP, that actually is more proximal. That the ADMP
Right here.
is actually underneath or just inferior to the lateral malleolus.
Over here, down here, you can't like over
Yes.
down here.
Right. Right.
Yeah.
Exactly.
So
And that's actually
what muscle is this?
the muscle that you're recording over is that flexor digiti minimi brevis, kind of the
Oh,
short flexor of the little toe.
so you know the Sabata book is wrong. Did you know
Quite,
that?
yeah, quite. No, I did not. Quite possibly. I mean, I've gone back to. I've looked at Gray's Anatomy and looked at. There's
Yeah.
some foot and ankle textbooks that I use from my orthopedic colleagues, and those I trust. There's one that starts with an S. I'm blanking on the name, but it's kind of the Bible when it comes to anatomy of the foot and ankle. And plus, I've dissected a number of cadaver feet, and I'm pretty confident in which muscles I'm referring to.
Yeah, my Bible is the Del Toro Bible when it comes to foot muscles. So Uh,
Well,
but
thank
I think
you.
these are we're getting into sort of intricate details, but it's important. And yeah, because some of the big general anatomy textbooks just say the ADMP is just one long muscle, and
Right.
it's not. So you're saying if you really
Yeah.
are anatomically correct, these are different muscles.
Yeah, if you look at the cadavers, and actually I love going into the anatomy lab when I can, is I think in the old days, they probably didn't look at the muscles in the detail that we're allowed to now, but the right about the fifth metatarsal base is when the ADMP becomes very, very small and is mostly tendinous. So while it does insert on the fifth metatarsal head or out by the little toe, most of the ADMP, by the time it gets to the fifth metatarsal base, it's mostly tendon.
Mm-hmm. Okay. But this is how you set up. Do you ever record more proximally? Is that what you record for
Baxter's nerve.
Baxter's nerve? Okay.
Yes, that's exactly where we would record. Basically, the E1, we leave E2 out where you have it on the fifth toe, but we move the E1 to about halfway between the lateral malleolus and the heel.
Okay, so kind of it's hard to see, but kind of right around here.
Yes, exactly.
Yeah. Okay. What would make you do that conduction? Would you do that in this patient, or would there be something different that would make you record from there?
You know, Devin, I'll tell you that I've not in this particular case. I don't know if it would necessarily be useful, because if you have your medial and lateral plantar, if they're both involved, then that automatically takes you to the level of the tarsal tunnel. And I think adding that Baxter's nerve branch doesn't necessarily help things, because if it's something that's at the level of the tarsal tunnel, and because the nerve, Baxter's nerve, comes off at it's either a branch of the lateral plantar nerve or it's a branch of the tibial nerve, but still comes off within the tarsal tunnel. Having that extra branch doesn't really help. It doesn't help me. Some people want to do it just because they want some extra confirmation. But in this particular case, I don't think it would be helpful. To me, the Baxter's nerve CMAP is mostly helpful when you're ruling out someone with a isolated problem for heel pain, which that's what Baxter's neuropathy. Unfortunately, Baxter's nerve goes right near where the plantar fascia inserts, and I've seen a number of cases where people either had a plantar fasciectomy or they had an injection of the plantar fascia, and the Baxter's nerve was inadvertently involved.
Okay. That's interesting. So I think if I could
answer, sorry.
Yeah, no, so I think what you're saying is if I'm gonna paraphrase, if you think there's a a tibial neuropathy at the ankle, and you do, let's say, a two channel like this, and they're both abnormal, it's not isolated. It's more proximal, so you don't need to record from another muscle.
Right.
Yeah, you don't need to record from the ADM here. Yeah.
Correct.
Okay. All right, great. Well, that answered a few of my questions. Let me show you a couple other. So we didn't do this on this case. We typically do, and I don't. This was an older case, so I'm not sure why it was not done. But we did compare the other tibial motor to the abductor hallucis. So this is the unaffected side, and this is obviously much better, and
markedly better.
Normal, yeah. So you have that, and then do you do the mixed nerves too?
Absolutely, yes. I mean, I'm a big believer in the nerve conduction studies, and EMG are all complementary. And I'd like to be able the fact that this person had sensory deficit on the foot, I would expect that the sensory or mixed nerve potentials would be involved. So I definitely would want to do it.
Would you do a Searle? That was the next nerve that was done. Or is that a waste of...
No, not at all. I mean, this goes back to what I was saying before. I'd like to get a normal nerve if I can. And even though I started with the medial plantar, I usually have a good sense of if it's going to be abnormal or not. But from a sensory standpoint, I think Searle's a great way to start. I mean, I get Searles in people that are in their 80s, so I feel pretty comfortable with this person being in their 60s. We should get a good Searle nerve.
Yeah, and I think also, as you said, it's although a diffuse polyneuropathy would be kind of unusual in this case, which is just unilateral, the Searle being normal here, I would think that helps make that less likely
Yes,
of diffuse polyneuropathy. Yeah.
absolutely. Yes.
Okay. So here's the next one. So this is the mix, what we would call medial plantar, but this is the mixed nerve stimulating the foot. So 62-year-old, that's what you get. What do you make of that?
So I'd be surprised if I couldn't get a medial plantar given the Searle that you got, assuming it's normal. I'm pretty confident, at least in my hands, of someone that had, I think his Searle was, what was it like, 16 microvolts or something?
Yeah, at B point
Yep,
for us is 14 centimeters, so it's 10
10.
microvolts.
Yes.
Yeah.
Okay. Yeah. I mean, I would say in general, someone over 65, I can still get, if the Searle is a given number, I would expect the medial plantar amplitude to be about 50%, give or take, 1 or 2 microvolts. So
Hmm.
with averaging, I think I'd be confident that I should be able to get something if it's there, assuming there's no pathology. Um,
So what if the I'll push you a little. What if the Searle in a 62-year-old is 5 microvolts, which we for us we would consider that still normal for over 60.
yep.
Would you expect to still get a medial plantar, or is that kind of at the point where you might not?
I think, yeah, I mean, it would be sort of a plus minus, but I
Mhm.
would still try it.
Okay.
And I mean, and I'm sure you use this trick all the time. If I did the Searle and like you said, it's like 5 microvolts. If I'm doing the medial plantar, I'm not going to spend an inordinate amount of time, but I am at least going to try it. If the patient feels um, the stimulus in the proper anatomic distribution, I'd expect to get something. I might need to average it. It might be, like 2 microvolts or something. But if they feel it and it's the right anatomic distribution, I should see something, especially given how well the machines are. We should be able to record something.
Yeah.
But again, I'm not going to spend like 20 minutes on it.
Right. Right. Yeah. And I think the point is, and so we didn't get a medial plantar. We tried the lateral plantar and didn't get one either. And I'm curious your experience. I know our normal values for the two branches and the lateral plantar mixed nerve is much it's lower than the medial,
Yeah.
smaller and lower. So in older people, we don't get a very good response many times.
Yeah, I don't expect to get the lateral plantar if I couldn't get the medial plantar, of course.
Yeah.
And if the medial plantar is there, uh, then the lateral plantar, if I'm going to get it, it's probably in the neighborhood of 50% or so of the amplitude of the medial plantar. So if I'm averaging the medial plantar and it's like 2 or 3 microvolts, the lateral plantar, I might try it, but it might be more perfunctory as opposed to spending, inordinate amount of time. And obviously, the exception to that would be if I think someone has a medial plantar, an isolated medial plantar neuropathy, and I've seen those, where I got the lateral plantar and the lateral plantar was larger than the medial plantar. So, but that's a different type of case.
Yeah. Yeah, exactly. And I think the other thing, and so, okay, so in this case, when we're not getting the plantars, the mixed nerves, we have the low tibial motor. Would you do anything else on nerve conductions?
I probably, since you didn't get anything at all with the medial and lateral plantar, I probably would jump to the other side and at least try to get one from that side, just to make sure that this isn't, like I said, some sort of asymmetric polyneuropathy. Oh, and you got something. Wow, that looks good.
So yeah, so we did. Yeah, and yeah, so
Wow.
actually it's 14. It's not a
Yeah,
perfect, so a bit of a shock artifact here, but and this is the
right.
lateral plantar 4. So it's
Yeah. Wow, that's nice. That's really good. And
yeah.
do you average?
Yeah, this one was averaged 3 times and this one was 4 averages. I would probably even
Okay.
average more because the baseline's a little noisy there.
Right. Yeah,
Yeah.
but still, definitely. Yeah. Yeah, that's terrific. That. Yeah. There's no question I would do those if I couldn't get anything on this other side, particularly since you got the Searle and it popped up so easily.
Yeah, and I think a point we both know, but it's worth making is we have to take the history into consideration, right? It's be easy to say, oh, he's 62, and no, an absent plant medial lateral plantar mixed nerve would still be within normal limits for our lab in a patient over 55 or 60. So, okay,
Hmm.
it's fine, but this is unilateral symptoms. So always compare to the other side if it's certainly unilateral and asymmetric.
Absolutely.
Yeah. Okay, so what would you do next? Would you do other conductions or go on to needle exam or
Yeah, I don't think. Yeah, I don't think I necessarily do any more nerve conduction studies. I did forget to mention. I probably would at least grab some F waves doing the tibial when we did the medial plantar. I usually at least will look at a few F waves to make sure there's not anything unusual, something I didn't expect, like axon reflexes or something like that.
Mhm.
Um, but that would be it.
Yeah. Okay.
I'd move
And
on to
then
the EMG then.
yeah, and so what is your approach to the needle examination in these kind of patients?
So in these cases, I would say I approach it one of two ways, Devin, and I try to read the room, so to speak. If the patient seems like um, the if they seem like they're okay, they're doing fine, not worried at all about they're they seem to be in good spirits, then I probably would plan on doing a number of needle a number of muscles with the needle exam. If I feel like they're getting a little skittish, then I might quote unquote go for the gold. But let's say this person seems like they're pretty good. I would try to do a normal muscle first. And in this case, I probably would do like either like medial gastroc, something more proximal, something in an S1. That way, if there is something there, do they have a superimposed S1 on top of something else? Um, so I probably would do, like I said, medial gastroc, tibant, something like that. Then I would proceed to the foot.
So what if the patient says, I'm going to allow you to go for the gold and stick one muscle?
Yikes!
Because that's all I allow people to do. Would you
I will, I will tell them this will be an incomplete exam, and I will
yeah,
present them.
right. Perfect answer. That's what I tell them too.
Yeah, yeah. I will tell them that I'm not even sure it's worth doing that um, because
Yeah.
yeah,
Because
um,
I mean, you could wait. We could play the game and say, well, you do proximal or distal, but then you still kind of need one of each if one of them's abnormal. I mean, I guess you could
hey
argue if
Devin,
you stuck a foot muscle and it was totally normal, then maybe that would
hey
help you.
Devin.
Yeah.
Can we pause 1 second? My resident is telling me something about a patient. Can I just pause for
Yes.
1 minute?
Yes.
Sorry.
It's okay.
Okay.
So I suppose if you stuck a foot muscle and it was completely normal, you might be able to say, well, there isn't a severe problem. But I agree, we would want multiple muscles.
Yeah,
So
and I would say at the bare minimum, okay, oh good, you have some muscles. Um, yeah, so yeah, lots
yeah,
of
so
proximal muscles.
yeah, so just for those listening, so what was stuck, what was examined was anterior tibialis, medial gastrocnemius, a couple more proximal, vastus medialis, TFL, and gluteus maximus. Those were all normal. Anterior tibialis had just some borderline high amplitude duration.
Okay.
Uh, so would you stop there or would you do more
Proximally or just in general?
in general?
Oh yeah, that I mean, I probably yeah, from here I would definitely go to the foot. This would be really more like a precursor, and I probably would have even have stopped at the vastus and or TFL.
Okay.
But I'd go, yeah, at this point I'd go to the foot.
What are your go-to muscles in the foot? What do you like? What are your favorite muscles, the ones you typically examine?
Sure. The abductor hallucis, I think, is an excellent medial plantar um, innervated muscle. It's considered S1, S2, depending on some of the books might have a little bit of L5, but that's a good medial plantar innervated muscle. Very easy to get into and fairly superficial, and it's pretty easy to activate. Um, so that's one. The other one from a lateral plantar innervated standpoint would be the fourth DIP or the fourth dorsal interosseous pedis. And that's something, that muscle is easy to get into. It's, you stick it in between the fourth and fifth metatarsal heads. Again, pretty easy, pretty superficial muscle. It's also S1, S2. But it's purely innervated by the lateral plantar motor nerve.
Okay.
And then I wouldn't do it in this case, but one muscle that we like to do for the Baxter's nerve or the first branch of the lateral plantar nerve is that ADMP, that muscle we talked about beforehand. If I'm thinking Baxter's nerve, in this patient, I wouldn't. But the other one in the foot that we would definitely have to do is the EDB. Because if we're thinking it's a tibial problem, a tibial nerve, whether it's medial plantar or both medial and lateral plantar, so the tarsal tunnel proper, I'm sorry, tibial nerve proper, then I would want to do the EDB, which of course is innervated by the deep fibular nerve.
Yeah. So that's interesting that I'm going to show you, we did do a couple others in the foot here. So first dorsal interosseous pedis, I don't know if you stick that. Do you think that's
I
lateral
do.
plantar? Or is that medial
Well,
plantar?
it's dually innervated, and you have it right. It's dually innervated by the lateral plantar and the deep. It's actually the deep fibular nerve.
Okay. Yep.
So
Yeah.
it gets dual innervation, and because of that, in someone with tarsal tunnel, I wouldn't necessarily do it if I didn't have to, because it doesn't help with regards to separating tibial nerve from the fibular nerve, if that makes sense.
Okay. Yeah. I see what you mean. Because if it's abnormal, that could be due to fibular involvement, or if it's normal,
Right,
it could be due to that muscle being more innervated by the fibular nerve. So
right,
normal or
right.
abnormal doesn't help you a whole lot.
It's a
Okay.
great muscle, I think, for PPN, because it's one
Hmm.
of the those distal muscles, and it's easy to get into. I think it's relatively well tolerated. In fact, it's better tolerated than the FDIM, the first dorsal interosseous manus, I think. And then it's a good S1, S2 muscle as well. It's pretty
Okay.
easy to activate too. The person can just squeeze your finger between the toes, or you can flex the toes, or you can extend them. So I don't think that, yeah, I think it's a good muscle from that standpoint. In this
Yeah.
particular case, I probably would not necessarily do it.
Okay. And this one, I don't do nearly as frequently the EDB, I'm sure, as you do. And I guess that my argument in this case would be symptoms are on the bottom of the foot. Fibular motor response is really good. Uh, Tibials are all abnormal. This looks and smells like a tibial neuropathy. So, but
Yeah,
I understand your point that you want to have a foot muscle that is normal to fully support that it's just the tibial nerve.
right.
Yeah,
I think, yeah, you said it exactly. Is that we're just trying to bracket
yeah,
what is abnormal with the normal findings.
yeah. What do you make of 2+ fibs in those foot muscles? Can't that be normal?
I'm biased, of course. That I've been doing foot EMG for a long time. I don't see 2+ spontaneous activity like that in normal muscles. Um, so I would consider that some sort of pathology.
What if it was 1+? What if it were a few
Uh,
fibs?
so I would want to make sure I can reproduce it. That Dan Dimitri talks about how and I'm sure you've seen this and heard this before, but sometimes when you're going into muscles that are really small and the motor end plates are close together, you can hear some electrical activity that may sound like abnormal spontaneous activity, but you really have to be able to reproduce it and listen to the firing pattern, listen to the rate, the frequency, et cetera, to really characterize that what you're hearing is indeed, regular and consistent with,
Hmm.
fibrillation potentials or positive sharp waves versus end plate potentials.
Yeah. I won't misinterpret that comment to insinuate you're insinuating I can't recognize fibrillation potentials.
Not at all.
I know,
Not at all, Devin.
but
You're the king when it comes to
but
that.
but it's no, it's an important comment because yeah, and one of the things when I teach and do some of the EMG waveform recognition workshops, and I show end plate spikes, and I say, what's the significance? And my point is, significance is not to misinterpret them as fibrillations. So I think it's a good point. I think the other point, and I'm curious, and I didn't do a whole literature search here, but I'm sure you know this, you well know this very well, that there are reports of fibrillations, not necessarily 2+ fibrillations, but a percentage of people will have fibrillations in some of the foot muscles, depending on what papers you read and believe. I don't know. I mean, this is just a summary of some of the papers. Do you believe that 15 to 20%? And this is can be just a couple fibrillations, not dense. Or you think that's
Right.
too high?
Yeah. Um, that, and those are excellent researchers. I know Andrea and Michael Harper. I've seen their work, so I think they're excellent. I would just say, if you look at there's a study that Dimitri did. I want to say like 2001 or something, and he compared the foot muscles, the AH and the EDB, to the paraspinals. And I think I want to say in 100 subjects, he found in one or two subjects that there was some fibrillation potential. So very, very few. And I think that concurs with my experience.
Yeah. I think this is a hard issue. Honestly, I struggle with this when and I don't stick foot muscles routinely. It depends on the problem, but I
Sure.
struggle with how much weight am I going to put if there are just a couple fibrillations. If there's 2+, I think that's
Right.
clearly abnormal. But the last
Yeah.
thing I want to do is overcall and give someone a diagnosis based on too little fibrillations, or a
100%
little
agree.
pocket. So it's a
Yeah.
hard balance.
Yeah, I think you're 100% right. And this is one of the things we teach our residents when one of the things that we do an EMG case conference, and one of the things we spend a fair amount of time on is in your report, what are you calling this? What is in your electrodiagnostic impression? And I tell the residents all the time that if you're diagnosing someone with an entrapment neuropathy, whether it's carpal tunnel, ulnar nerve at the elbow, maybe fibular nerve at the knee, tarsal tunnel. Even though, I mean, I know this, you know this as well, that even though like tarsal tunnel isn't nearly as common as carpal tunnel, it doesn't really matter because if you put that diagnosis down, eventually someone will see that and they'll say, "Oh, you have tarsal tunnel. You need surgery."
Mhm.
Simple. That's the reason for your pain, numbness, tingling, etc. So I'm 100% in agreement with you that don't overcall the EMG. I think that's something that Ernie Johnson used to say as a one of the things that sort of a caveat. So I would agree with you. I mean, to me, if everything fits clinically with the electrodiagnostic findings, I'm comfortable calling it. If we're
Yeah.
just seeing just minor stuff and nothing else fits, I'm a little hesitant, and I might even just say, you know what, can't say for sure. Bring this
Yeah.
person back.
Right. And in this case, so this is pretty much all that was done, but let's assume the EDB was normal. Would you
Hmm.
be comfortable calling this tarsal tunnel?
Um, I I think in this case, because you had easily 2+, your conduction
Mhm.
studies fit.
Yeah.
I think I definitely would be leaning toward calling it tarsal tunnel. I'd also, my colleagues, I don't do this, but my colleagues that do ultrasound,
Yeah.
I would absolutely say, you know what, they need a ultrasound of the tarsal tunnel or an MRI if they want to, but some advanced imaging to see what's going on there.
Yeah, I agree. And I'm not going to belabor the ultrasound point, but we do this. This is not, I'm going to just show you an ultrasound. It's not from this patient, but this is one of the reasons why ultrasound can be helpful. And, this patient, this came from a patient with a tibial neuropathy. Here's the tibial nerve at
Okay.
the ankle and had a huge mass there, right? Not the patient
Whoa.
I presented, but here's the nerve, and then here's
Yep.
the big mass. So yeah, I mean, we look for, we joke we kind of joke, oh, tarsal tunnel, it doesn't exist, but it does exist. And sometimes it can be a mass and sometimes it is entrapment, but we have to I think what you're saying, we have to be really clear that the symptoms are that the findings all fit and it's not just a bilateral polyneuropathy that's
Right.
mimicking it. Yeah.
Exactly. Yeah, the other thing too is that I've seen a number of cases from referring doctors that say so and so has what they believe is tarsal tunnel on the basis of overpronation or
Mhm.
something biomechanical going wrong in their foot. And honestly, I just don't see that. And I am definitely nervous about calling that tarsal tunnel because I'm 100% sure that those people will be operated on at some point.
Yeah, I agree. I want to end with one more thing here, one more guideline, and we could spend another hour discussing tarsal tunnel, but this is the AANEM guidelines. I'm sure you're well familiar with it. You might have been involved in putting this
I
together.
was.
Yeah. So
Yep.
what do
Yeah.
I'm curious, this
Patel
is
was the
old,
leader.
but
Yep.
the thing that strikes me is the prolonged distal latency is number one and sort of looking for that. And I'm curious your experience. Do you see that, or is it mostly drop in amplitude?
Yeah, I do not see that, and I'm embarrassed to say that. Yeah, we have not been able to do enough research to show that is, in my opinion, incorrect. I rarely see the prolonged distal onset latency as being consistent with tarsal tunnel. It's more frequently, or I would say 100% of the time, I've seen it has been a drop in amplitude, whether it's the CMAP, the SNAP usually, or the SNAPs are gone, CMAPs are down in amplitude. Can the distal onset latency be prolonged as a result of the amplitude being or loss of axons? Certainly, but it isn't necessarily, I think, part of the overall electrodiagnostic picture.
Do you think that's because I'm going to just stop sharing that? Do you think that's because in that condition it's less commonly demyelination and myocompression, or is it? I always wonder, is it that our values for prolongation of the latency are maybe not very sensitive, so it has to be really demyelinated before you see that, and most of these are axonal loss.
Yes, I yeah certainly my bias is that it first of all most of the cases, I can't think of one really that was more demyelinating, but most of them are axonal at first, and then the axonal part become markedly reduced, and then the demyelinating component can show up. And I do think, unfortunately, our parameters for the demyelinating part are relatively narrow,
Mhm.
and so unfortunately, it can be um, mis I would say misinterpreted, the
Yeah.
findings.
Yeah. And I think that's a really important point. I think there's this kind of misunderstanding that it's just the equivalent of carpal tunnel syndrome, and I think it's obviously very different. It's different nerve, different degrees of myelination and compression and repetitive compression. So, I mean, you've taught about this for years, and you can't really compare. It's not the carpal tunnel syndrome of the foot, right? It's a
Right.
totally different
100%.
entity.
Yeah, you said it best. And yeah, I definitely am still, like trying to teach that in the workshops and the courses that we have, because forever carpal tunnel and tarsal tunnel will be linked just because of that tunnel. But the pathophysiology is very different. The anatomy is very different, and that's one of the reasons I like teaching the courses, because I'm all about anatomy, and I think if you understand the neuroanatomy of the foot and ankle, you'll understand why things are different when you compare that to the hand.
Yeah. Yeah. No, good point. Do you think turkeys can get tarsal tunnel syndrome?
Say it again. Who?
Do you think turkeys can on
Turkeys.
Thanksgiving? Yeah. I don't think they have tibial nerves.
I don't think so either.
Well, this has been phenomenal. I know you and I could spend another hour discussing all this, and I always learn every time I hear you speak or listen to you, and it's great. I think people are really going to learn from this discussion.
Well, that's great. Yeah, I appreciate that. I mean, I'm the same way, Devin. I love coming to your courses at the ANEM meeting. I'm always learning something. So I appreciate the opportunity to discuss this with you, and I'm happy to do something like this again if you want to.
Absolutely. I might even get you for a lessons from the lab live like we did at AANEM this year with the whole audience. That was
I
fun.
would love I would love to do that.
Yeah, but this is great. And I really appreciate your time that you took out of your day. I hope you have a wonderful Thanksgiving and holiday season. And it's always great to see you more so in person, but even by video.
Yes. Thank you, Devin. Same. Have a great Thanksgiving.
All right. Take care. Bye bye. I hope you've enjoyed this episode of Lessons from the Lab. There is so much information in the discussion that Dr. Del Toro and I just had. It's a challenging diagnosis, and these are tough cases. These are cases that sometimes are difficult to know exactly what's going on. We do our best from an electrodiagnostic standpoint to localize the problem, but sometimes it requires other testing, and sometimes we don't always come up with the definitive answer as to etiology. But hopefully, this will make you think about conditions such as tarsal tunnel syndrome or tibial neuropathies. There's a lot of things that we think about as neurologists and physiatrists every day. And that's what keeps our mind going. That's what keeps us thinking. And that's what makes us happy. So, bye bye.